It's okay, sir?
Yeah, it's working.
Okay, no, okay.
Please.
Okay. Okay. So I welcome all the faculty members, Professor Manish Khanna, Professor Rajesh Gupta, Dr. Vishnu Senthil, Professor Alok Agrawal, Professor Keshkar, Professor Jha, Professor Mukherjee, all the panelists, Dr. Rameshwaram, and all other panelists to please join this on Indian Orthopedic Rheumatology Association. So now I request the President, IORA, Professor Rajesh Gupta, to address.
Good afternoon, everybody. So I welcome you all on this third webinar. This is our third webinar. First we had on gout, rheumatoid. Second was on gout, and this is the third, spondyloarthropathy. So we have started this series. Let's see how much we can go. Maybe one or two more, because we have other activities coming up. So we are having our hand conclave at Cuttack on 21st of April, and then on 19th of May we are going to have our spine conclave at Jammu. So these few activities, and then we are going to have our biennial conference at Varanasi. On the 30th, sir, it is 30th and I think August and 1st September, I suppose.
Yes.
Yeah. So with these few words, I hand over to Arti again to invite the first speaker.
Now I invite Professor Manish Khanna, the founder, advisory, Indian Orthopaedic Rheumatology Association, the chairperson of Indian Stem Cell Study Group, the chair of Educational Day World Orthopaedic Association, editor-in-chief, Index General, International Journal of Orthopedics Rheumatology, and the editor of Textbooks of Orthopedics Rheumatology, Dean Academics, join in Mayo Institution, Lucknow. So he's going to speak now today on how to approach the spine in orthorheumatology. Dr. Manish.
Thank you so much, Dr. Arti, for the kind introduction. Is the slides visible?
Yeah.
Wow.
Please.
Yeah, thank you
Yes,
so much.
sir.
So approaching spine orthorheumatology, definitely with the last 15 years almost now, when we started orthopedic rheumatology, we are now moving ahead, working up for the surgical aspects of the orthorheumatology, especially the spine, the wrist and hand, which are a little bit of neglected area in the sense that when the surgery is being required, what type of surgery has been indicated, what are the diagnoses, how the treatment variations can be picked up. So that's why this spine orthorheumatology is a very interesting specialty. It is a medical surgical specialty useful for orthopedic surgeon, especially those who are dealing with these medical orthorheumatological spine cases. And the rehabilitation part is also very important, which is a way to go to a sky's the limit for learning its way backs. Now, Textbook of Orthopedic Rheumatology Association is already having a published book, which is having a lot of papers, a lot of chapters on the subject. Especially, there are a few chapters on the spine aspect of orthopedic rheumatology. Now, why this knowledge of spine orthopedic rheumatology is so important? So, gone are the days when the patient, when comes to the OPD with a backache, so we say, okay, backache, so just give a muscle relaxant and exercises, blah blah, all those things, and we consider each and every backache to be a sciatic or disc issues, compressive issues, pathologies, disc pathologies. But actually, it's not the way. There are a lot of reasons. If you go to the literature, you can find out there are a number of causes of backache. So we can't discuss this. If you're going to discuss it, it will take 2-3 days actually. Here's a complete list in which even a nephrologist may have a patient with a backache. So with a renal involvement, with a stone, something like that. And a posture is definitely important, but most important thing as an orthopedic surgeon, which are important is sacroiliitis or spondyloarthropathy, which is this evening's topic. Now, arthritis, definitely it has been considered, okay, you are having arthritis means you are having simply a problem of hand, foot, ankle, shoulders. No, it's not always. Arthritis may also be there in the spinal, in the axial form. And if it is an axial form, it is called as spondyloarthropathies. Now, we encounter such type of patient in our usual clinical practice. As a surgeon, we see so many patients who come to us with their traumatic issues, especially lower limb surgeries, and after doing the surgical intervention, because usually in the surgical intervention, we go for a lower limb surgery in which spinal anesthesia epidural has been given. Many times, because of a long-standing bedridden portion of the management part of such patient post-operatively, or the immune status gradually slows down, the patient is a little bit of in stress and depressive. So many times, the silent spondyloarthropathy portion may be broken. So we have to take a very detailed history, because many times, even if you see in your OPD, sometimes say, okay, I have a cesarean section, so I'm having a backache. This is a very usual presentation in the females with 40s and 50s, females with the obesity, with the diabetes, with 40s and 50, and they consider it as a normal. No, it is not normal. That we have to pick it up from our own experience. So arthritis, that is seronegative, positive, osteo-gouty, they are now the way back. The main thing is now the low backache, which may be a symptom of the such patient. Now, a patient with a sometime a patient which we come to an OPD, as I've already mentioned, I think I've missed my slides. Yeah. Now, whenever we see such patients, now here the first thing which is very important, I always ask my residents also to remember, just with a proper history, although it's not 100% positive always, we need to differentiate an inflammatory backache and a mechanical backache, which simply by talking, simply by discussing with the patient, we can pick it up. So inflammatory backache is a backache which is having a insidious onset, especially the pain is there during the inactivity. No improvement with rest is there. But if the improvement with rest is there, it is a mechanical backache, which is of varying nature, which we know. Now, the key clinical markers for the diagnosis of inflammatory backache is definitely, we all know, to some extent, it is HLA-B27. But HLA-B27 is again a thing which is not always a key thing, because to some extent, HLA-B27 is normal in a normal population. So it's always not a thing which is to be diagnosed. Morning stiffness is definitely important. Improvement of exercise is definitely important. Restricted spinal mobility. When these things are there, then always a click in the mind for the spondyloarthropathic feature in which the sacroiliitis is a very important thing, and we are going to discuss this throughout this next 1.5 hours. So such cases may be a case of early spondyloarthropathy, which may be self-limiting initially, which was a self-limiting, patient was not having any problem, but later on, because of the physiotherapy, because of the stress, because of the lying down, because of varying reason, it may precipitate. So, and of course, sometime what happened, we take a history of the patient, and with the patient in a post-operative period, they later on say they have a backache, they have a pin-pricking sensation, but actually it is going towards a fibromyalgia condition. But again, it is also inducing autoimmunological changes. That imbalance which is produced may give rise to the starting of these patients. And these patients, if they can picked up at a very early stage, it gives a wonderful result. As I've already mentioned, ANA positive, HLB27 positive, which has always been there in so much laboratory preparation. ANA is also positive to a normal population. So it is also not very significant that always it is a lichen planus or, all these conditions. So we are not supposed to concentrate on the investigation. Just the history is more important. And of course, in an earliest form, in these all spondyloarthropathies, if we can pick it up, the enthesitis, at a very early stage, then definitely it will be wonderful. But it's not always required to go for MRI, costly investigation. If you're in suspicion, just ask your sonologist friend to go for it and just to have an option for this. Because 1 to 2% of all these low backache are spondyloarthropathy patients. So we can see the rheumatoid arthritis, second to rheumatoid arthritis is approximately 2% of Indian population, 1 to 2%. And next is spondyloarthropathy. So how can we say a patient of a backache is a mechanical problem? No. This patient may be in 0.5% of the patient, which is a big chunk of the patient. Initial portion, which is not very much clear, that is undifferentiated arthritis. And there definitely you can take a help of HLA-B27, but we have to remember that it is only prevalence of HLA-B27 is a normal in approximately 6% of the population. So again, we can't go for it. So we need to evaluate this patient, for which this entire today's seminar is all about. And yes, don't worry if you're not able to make a perfect diagnosis of spondyloarthropathy. It is undifferentiated, not clear, not labeling into AS, not labeling into reiters, not labeling into any particular type of arthritis in most of the cases, does not make a difference at all. We need, the treatment is the same, which we'll discuss this evening. But if it's undifferentiated, even then it has to be picked up and to be taken care of as early as possible. If it is an axial joint involvement, it's definitely a wonderful. But unfortunately, many spondyloarthropathy, they don't have even axial involvement. They only present in a peripheral part. And that has a very bad prognostic feature. And there the treatment is also very topsy-turvy, truly speaking. So we should wait from pre-radiographic stage to radiographic stage, back pain, active sacroiliitis, back pain to syndesmophyte. At this stage, anybody can diagnose. The best part, the best sense for orthorheumatological surgeon is to diagnose at this stage, so that the patient cannot reach to that later on stage. So it is a specialty which require not only orthopedic surgeon, also the neurosurgeon, the psychiatrist, the psychologist, physiotherapist, physician, rheumatologist, definitely to some extent. So to take care of the need for the learning and to make the learning curve more smoother. We should try to update our orthopedic rheumatology knowledge with the recent trends. That is what the aim for this webinar for this evening is all about. We association is having our own international journal, which is indexed in Index Copernicus, Google Scholar, Indian Citation Index, Publon. So we are moving ahead. Now it has been indexed, and it is inviting original paper, meta-analysis, systemic review. This December issue has already been on the website. It has been there. One can go for it. And definitely, yes, the textbook of orthopedic rheumatology is a gold mine for many of these unanswered questions, which need a thorough workup. Thanking you for a very patient hearing. Thank you.
Thank you, Dr. Manish, for such a wonderful talk, because it's a fascinating topic, rheumatoid. And of course, it is associated with autoimmune disorder. In a routine OPD, we see so many patients and we miss it. It's just that backache is there and we are not able to differentiate it. Being a
Correct.
female orthopedic surgeon, I see so many patients, so many females who come to me in the orthopedic OPD, and I see them. I mean, from my time, I say that it's just like a backache. It could be it could be sciatica or a disc prolapse. But now, with your knowledge and with your experience, we are able to make it that there are so many spondyloarthropathies, either it's an axial or a non-axial, that how to differentiate between these, because it's not that ortho people are involved, the ortho physician, but the rheumatologist and the physiotherapist. So it's a multidimensional kind of thing. Thank you, Dr. Manish. Any questions, or we should make the questions at the end to Dr. Manish, to all the panelists, and to all the
Dr.
speakers?
Manish has to leave. I think if any questions to Dr. Manish can be taken now.
I have a single question.
So,
Yes.
Sir, just I wanted to know any criteria or straight cut criteria which could tell us the differentiating point of spondyloarthropathy and spondylolisthesis or spondylolysis. I mean, the mechanical or reactive arthritis of spine, because that should be a clue point for the all beginners and so many people.
very, very nice question, sir. Thank you so much. Actually, we all are aware about the spondylolisthesis, and we fix, though I'm not a spine surgeon, but we have seen it, it's been fixed up. But truly speaking, there is a correlation between the two. If it is not a mechanical, but most of the time, spondylolisthesis may be a consequence of spondyloarthropathy, because the spondyloarthropathy have a facet joint involvement with the arthritis, with the degeneration, with the decapsulation and everything. Gradually, the patient may shift to spondylolisthesis, which requires surgical intervention. And where the surgical intervention is being given, then we usually forget for the treatment part, which is the pathology, which is the cause, which may be present. Suppose we are fixing L5 and S1, which is the most common is L5 over S1, but suppose we are managing it. But maybe such of changes, facet joint changes may be present throughout the other vertebra also, which needed to be taken care of. But as such, there is no laid down criteria for demarcating this is this, but this is spondylolisthesis is truly a mechanical, in the sense that when the listhesis has been there, it needs fixation. So what I feel is that is why we are always propagating spine orthopathy, spine orthorheumatological conferences, conclave, to invite faculty to have surgical fixation aspect, learning the surgical fixation aspect for the listhesis, but also simultaneously to manage such patient, because without a fire, there is no smoke. So unless and until the patient is very obese, diabetic, and all those reasons are there, but why always in all the diabetic patient or obese patient, they don't have a listhesis. They only have a listhesis if there is a pathy, and the pathy is in the facet joint.
Thank you, sir. Thank you for your kind notes, sir.
Right, sir.
Thank you, Dr. Manish, for such a lovely talk. Now I invite Professor Rajesh Gupta, President, Indian Orthopaedic Rheumatology Association and Professor and Head, ISKCON's Medical College, Jammu, to talk on epidemiology, the genetics and the pathogenesis of spondyloarthropathies.
My screen visible already? Is my screen visible?
Yes, sir, it's visible, sir.
Yeah, so already visible, right? So good afternoon. I'm going to talk on spondyloarthropathies, epidemiology, genetics, and pathogenesis. Now, we all know that spondyloarthropathies is a family of diseases that share certain clinical features like inflammation of the axial joint, asymmetric oligoarthritis, enthesis, eye and bowel inflammation. Now, what is this SPA family? Now, SPA family constitutes by ankylosing. Please unmute. Please mute, sir.
We'll request everybody to mute the mics except the speaker.
Thank you. So this family is ankylosing spondylitis, SPA associated with the psoriasis or psoriatic arthritis, undifferentiated spondyloarthritis, reactive arthritis, SPA associated with Crohn's disease and ulcerative colitis, and juvenile onset spondyloarthritis. Now coming to the epidemiology, spondyloarthropathies, they are relatively common. It affects around 0 to 5% to 2% of the Caucasian population. It is common in young adults with onset before the age of 40 years. Male to female ratio is 2:1. Ankylosing spondylitis and the undifferentiated are the most frequent types, and the much less frequent is the reactive arthritis. It is negative to rheumatoid factor, ANA, and mostly involve the axial skeleton. Now, individually, when we talk of ankylosing spondylitis, it is a chronic multi-system inflammatory disorder involving primarily the SI joints and the axial skeleton. Male to female ratio is 3:1. Age of onset 20 to 40 years. The 90% of the ankylosing spondylitis patients are HLA-B27 positive, but only less than 5% of the HLA-B27 patient, the population, they develop the ankylosing spondylitis. The prevalence is 10 to 30% among the HLA-B27 positive adult first degree relative probands, and concurrent dense rate in identical twins is 65%, and in the non-identical twins, it is 23%. Now, psoriatic arthritis, men and women are affected equally. Age is 30 to 45 years, and 60% of the patients are HLA-B positive here. The 10 to 15% of the patients with the skin manifestations, they develop the psoriatic arthritis, and the skin manifestations, they precede the development of the arthritis. Reactive arthritis, Ritter syndrome, is most common in young men aged 25 to 35 years. It follows enteric or urogenital infection, and it is associated with the urethritis or conjunctivitis. Here, 80% are seropositive for HLA-B27 positive. Arthritis associated with the inflammatory bowel disease occur equally in men and women, and 4 to 50% of the inflammatory bowel disease patient have extraskeletal intrasternal manifestations like musculoskeletal one. Now, coming to the genetics, we all know that genetic component is very well established in the pathogenesis. In more than 90% of the cases of radiographic SpA, the susceptibility is genetically determined. There is a strong association with the major histocompatible complex class 1 antigen, that is HLA-B27. 90 to 90% of the patients with ankylosing spondylitis are positive HLA-B27. The risk of this disease developing is as high as about 5 to 7% in HLA-B27 positive individuals. The risk is substantially higher in HLA-B27 relative of the patients. However, most HLA-B27 positive individuals remain unhealthy. Now, what is HLA-B27? It is an alpha chain and encoded in the beta locus of the MSC chromosome 6 and in non-MSC encoded beta chain beta-2 microglobulin. The primary function of the HLA-B27 in complex with the beta-2 microglobulin is to present short chain antigenic peptide for recognition to the cytotoxic lymphocytes. The ability of the HLA-B27 to bind a unique set of the peptides may be the underlying reason for its disease association with the SpA. We will be discussing this in detail in the later slides. So this is a HLA-B27 molecule having the alpha chain here with the cleft on the top. This cleft is for peptide binding, and this is a beta-2 microglobulin. This transmembrane domain is for attachment to the T cell receptor over the CD8 cells. Now, there are other genetic determinants also apart from the HLA-B27. Interleukin 23 receptor involved in the T helper cell 17 pathway, and the endoplasmic reticulum aminopeptidase 1 involved in the peptide processing and potentially linked with the HLA-B27 in the presentation of the antigen. Now, coming to the pathogenesis, it is not fully understood. It is thought that it is due to the interplay of the genetic, immunological, and various environmental factors. So it is very complex thing. Now, when we talk of first hypothesis, that is arthritogenic peptide hypothesis, here the presentation of the unique set of the antigenic peptides, that is by the, it may be bacterial or self antigen, by the HLA-B27 positive alleles to the CD8 T cells. Now, there is cross-reactivity and cytotoxic cell response leading to the interleukin 17 production, which leads to the joint and the tissue inflammation. So this is the first hypothesis. Second one is the unfolded protein response. The HLA-B27 tends to fold slowly and often misfolds. So there is a structural change in the HLA-B27. The misfolded HLA-B27 molecule accumulates in the endoplasmic reticulum of the cell. So this excess of misfolded HLA-B27 is not eliminated or destroyed by the cell. So there's an increased accumulation in the endoplasmic reticulum. This leads to stress response in the endoplasmic reticulum. So there is unfolded protein response. There is upregulation of the UPR genes, which activates the production of the pro-inflammatory cytokines like interleukin 17, interleukin 23, and interferon gamma. Third hypothesis is formation of the homodimers. Now, HLA-B27 heavy chain homodimers at the cell surface. Now, homodimers, they bind to the certain killer cell immunoglobulin receptors on the NK cells, natural killer cells, and the T cells. There is an upregulation of the pro-inflammatory cytokines interleukin. Now, few lines, what are the homodimers? Homodimers, basically, they are peptide chains of the same number of the amino acids type and the kinds. Basically, it is the aberrant form of the HLA-B27. Now, coming to another hypothesis, that is a ERAP polymerism hypothesis. ERAP1 and 2, they are basically localized to the endoplasmic reticulum. Now, their main function is to trim the peptides for loading and presentation by the HLA molecules. Now, basically, the long peptides, they are trimmed to around 6 to 8 amino acids for presentation to the HLA molecule. Now, that is the function of the ERAP1 and 2. Now, there is a dysregulated ERAP1 and 2 activity, which may alter the immunodominance and modify the activation of the cytotoxic T cells and the NK cells, which affects the adaptive and the innate immune response. Last one is the gut inflammation and dysbiosis hypothesis. Now, there are HLA-B27 mediated changes in the gut microbiome, which may lead to activation of the immune response, molecular mimicry, and the increased intestinal permeability. Now, 60 to 70% of the patients with the SPA present with the microscopic evidence of the gut inflammation, and the 7% of the patients of ankylosing spondylitis will also have inflammatory bowel disease. Now, if you see this diagram, this is a summary of all the hypotheses. This APC is the antigenic presenting cell. It may be a macrophage or it can be a dendritic cell. Now, here in the endoplasmic reticulum of this cell, the ERAP1 and 2, it presents the small peptide over to the HLA-B27 here on the top. This HLA-B27 loaded with the peptide. It is expressed on the surface of the cell over here, and then it attaches to the T cell receptor of the CD8 cell. So it activates the CD8 cell and leads to the release of the interleukin 17. Now, second one is I have already discussed over the bottom here is the endoplasmic reticulum stress. It leads to the production of the interleukin 27 from the macrophages and the dendritic cells. Third one is the homodimers here at the top again at number 3. Now, these homodimers, they attach to the killer immunoglobulin receptor on the NK cells and the T helper cell 17. So it again leads to the release of the interleukin 17. Fourth one is at the bottom is the dysbiosis, and it also leads to the stimulation of the interleukin 23 and interleukin 17 axis. So all these, release of the interleukin 17, 23, they activate the osteoblasts, fibroblasts, synovial and the macrophages, and they further lead to the release of the tissue necrotic factor alpha. So tissue necrotic factor alpha, along with these interleukin 17, 23, it acts on the target cells like bones, synovium, and the gut, leading to the inflammation. So this is all about this, hypothesis diagram. So the interaction of the HLA-B27 with different forms of the stress leads to an auto-inflammatory immune response. There's a production of the pro-inflammatory cytokines like interleukin 17, 23, tissue necrotic factor, and the activation of other leukocytes. There's inflammation leading to synovitis, myxoid edema. There's a pannus formation and subchondral granulation tissue. There's a marrow edema leading to enthesitis and chondral differentiation with eroded joint margins, fibrocartilage regeneration, and ossification. So, in conclusion, the exact mechanism of spondyloarthropathy pathogenesis and the role of HLA-B27 is still, pathogenic role of HLA-B27 is not is still unclear, and it is postulated that more than one mechanism may lead to the disease occurrence. Thank you.
Thank you, Dr. Rajesh, for such a lovely talk. It's like very interesting that still it's HLA-B27. It's controversial whether investigation, in some cases it's like positive, some cases it's like negative. So it's very unclear to us that the role of HLA-B27, that it leads to so many autoimmune disorders. Thank you so much, Dr. Rajesh Gupta. Now I invite Dr. Vishnu. He's assistant professor in Government Rheumatology Hospital, Chennai, and he's a fellow of IORA, Indian Orthopaedic Rheumatology.
Arti, I got a question.
Yes, sir.
Yeah.
How are you, Arti? You are fine?
Hanji, sir, I'm fine, sir.
Rajesh, my question was, see, every time you see a patient of doubtful ankylosing spondylitis, but all the time the HLA-B27 is not positive initially. Yeah. So the role of MRI to visualizing the SI joint, what is your opinion about that?
Sir, HLA 27 is not present in all the cases. Even if it is HLA negative, we have to think of the diagnosis, you know. And there are criteria which are going to discuss in the next slide, you know, next presentation. There are clinical criteria. We have to be, you know, we have to keep in mind everything. It is not only HLA-B27.
HLA-B27.
Yes.
Yes. Thank you.
Good evening, sir, and thank you, ma'am, for the wonderful introduction. So I'm going to talk about the clinical criteria, classification, touch upon the radiology and laboratory investigations for spondyloarthropathy. So why the classification? Why should it be classified? So even though with the presence of lot of scientific aspects are being missed, there is an average delay of 5 to 6 months from the onset of symptoms to its diagnosis by most of the physicians. So moreover, most of the criteria which have been described in literature have developed a classification criteria more for a clinical research, and when it is used as a diagnostic tool in practice, it has a low sensitivity, and so it has a low specificity and has a high sensitivity, which leads to false positive rates, as given by this article published in World Journal of Orthopaedics by Osgur Akol. So coming to the overview of the classification, Professor Dr. Manish Khanna has told about this very beautifully. So mostly the arthritis comes of the axial manifestation and also as the peripheral manifestations. So generally the axial or the radiographic axial spondyloarthritis are most commonly called as ankylosing spondylitis, and the non-radiographic we have the non-radiographic where we don't have the proper clinical features of SI joint involvement and everything, and further investigation managements are needed. So coming to the other part is the peripheral spondyloarthritis, which consists of the psoriatic arthritis, the reactive, and also called as undifferentiated, a large group of undifferentiated spondyloarthritis and other enteropathic associated arthritis. So coming to that, we have various classification, the Rome criteria and the New York criteria, the modified New York criteria. So nowadays, the assessment of Spondyloarthropathy International Society remains the gold standard criteria in diagnosing the ankylosing spondylitis at present. So it consists of the following features most commonly: the age of onset less than 45 years, presence of insidious onset, improvement with exercises, no improvement with rest, and mostly pain at night, and also associated with peripheral conditions like uveitis, oral ulcer, urethritis, psoriasis, and IBD. These are peripheral manifestation of spondyloarthropathies. So the major clinical features, they have the sacroiliac and the spine involvement. Sacroiliac and spine involvement, the hip and shoulder, and we also seen the various peripheral arthritis, and also involvement of the sternoclavicular, costochondral, mandibular sternum, and also presence of costochondral inflammation. And we have the dactylitis in 6% of the case, and sometimes even the neck pain can be a presenting symptoms, and enthesitis or extrapinal manifestations are present in 30 to 35% of the cases. And there are various scales are present, the LEI scale, the masses, and the spark scales, where depending upon the number of sites, these scales are where depending upon the various number of sites, the positivity rate is indicated depending upon the various scales. So the patient should be evaluated further even with the slightest clinical suspicion. So next after the clinical, so the imaging methods consists of the X-ray, MRI, and the laboratory investigations. So coming to the X-ray, the sacroiliitis grading most commonly used as the New York criteria. In this, it is divided into the grade 0, grade 1, grade 2, grade 3, and grade 4. So grade 1, we have only the suspicious changes are present, and grade 2, there's minimal abnormality or small areas of localized area of sclerosis or erosions are present with no alteration in the joint width. So grade 3 is the partial ankylosis, and grade 4 is a complete ankylosis, or there is a loss of disappearance of the joint line in the X-ray. So when is the MRI or CT indicated? So most of the times the X-ray, there not be any clinical features, and even though presence of X-ray there may be findings, but in those cases the HLA-B27 might be negative. So in those cases the MRI might be useful. So the MRI in this, the most prominent feature is the presence of the bone marrow edema or osteitis in the T2 images. So this is the required MRI features to be present, and inflammation must be clearly present and located in the typical anatomical region or the subchondral bone. So MRIs, these two features are highly suggestive of spondyloarthropathy. So when this feature is not present, there may be allied features which are not required or which are not considered, or presence of any other inflammatory lesions such as synovitis, enthesitis, or capsulitis without concomitant bone marrow edema are not sufficient for definition of active sacroiliitis on an MRI. And in the absence of presence of MRI signs of bone marrow edema or osteitis in the subchondral bone, there might be some in cases where the structural lesions are there, such as fat metaplasia, sclerosion, or erosion or ankylosing, which also these also don't meet into the definitive criteria of active sacroiliitis on MRI. The Spondyloarthritis Research Consortium of Canada, or the SPARC, they have the MRI index. So each slice has a maximum of 12 scores. So 8 for edema, 2 for the intensity, and 2 for the depth of the bone marrow edema or osteitis. So in this, there are 6 slides which are taken and maximum score. So 72 is the maximum score. So it is being classified as mild, moderate, or severe sacroiliitis depending upon the scores in each slices. So coming to this article, what is the diagnostic accuracy of these investigation in spondyloarthropathy? The current imaging guidelines are generally we take an X-ray which is followed by an MRI in conditions of axillospondylorthropathies or spondyloarthropathies. So when combined with X-ray or with MRI and with MRI alone, there is no added value on reader's performance. And generally in this article, the radiography is considered inferior to MRI or CT. So in CT has high specificity and a decreased sensitivity compared to MRI. So low dose CT is generally highly useful in detecting structural lesions of the sacroiliac joint. These structural lesions are mostly confined to the cortical or the trabecular bone, which are directly seen in the thin slices of CT. So CT has high specificity and MRI has high sensitivity but less specificity, leading to increased false positive readings, and also present in conditions of mimicking bone marrow edema, they're positive. So these are the particular examples. So if we see in this second X-ray and in the fourth X-ray, so these are the two cases which are in this case the X-ray. These are HLA-B27 positive cases in which in X-ray there are not much erosions are seen. But when we come to see and also in MRI not much of the bone marrow edema seen. But when you come to the CT, this low dose CT, they show structural changes in the sacroiliac joint of the in the second and fourth this in HLA-B27. So initially by readers, these two X-rays were read as negative for axial spondyloarthropathy. So in this third case, if you see, the viewers have read positive for axial spondyloarthropathy, but these conditions, when you take the CT scan, it has shown that it is not actually axial spondyloarthropathy, but similar other structural changes are mimicking or some other changes of structural arthropathy or low backache or other conditions we've seen. So coming to the serological biomarkers, the most commonly taken tests are CBC, ESR, CRP, HLA-B27, and others advanced markers are ILA-17, ILA-23, and ILA-22. In this article, it has shown the significant correlations between ILA-22 and increase in ankylosing spondylitis functional index in severity. So the association of coming to the association of spondyloarthropathy with HLA-B27, it is seen that 90% of the ankylosing spondylitis have HLA-B27 positive, but it slowly decreases in reactive arthritis, psoriatic arthritis, and IBD associated arthritis, where in these cases the HLA-B27 from 60% it drops to 25% of this condition present in this condition. So coming to the sensitivity and specificity of ESR and CRP in evaluating disease, the sensitivity ranges from as low to 39 to 40% to moderately high to up to 80%, and specificity also has a wide range from 40 to 86 to 87%. And coming to the sensitivity and specificity of HLA-B27 in ankylosing spondylitis, it is high as sensitivity is high as 82%, but specificity is quite low, about 68% respectively. So coming to summarizing, so spondyloarthropathies are often missed in non-specialized settings. So history is very important, and there are many mimickers for axial spondyloarthropathies. So if you have to take an X-ray, and in X-ray, if you are not able to see the sacroiliac joint condition or erosion, you can go for an MRI or CT scan. And in HLA-B27 negative patients, and most importantly, no single test can reliably diagnose or rule out spondyloarthropathies. So decision cannot rest on individual symptoms or test results. So it is a multimodal management from history, clinical findings, investigations, radiological investigations, and clinical findings, and always assess with people with low backache. And when you find people with low backache less than 45 years and it has lasted for more than 3 months, I have a high suspicion of axial spondyloarthropathy. And also when these type of patients, when they also present with peripheral conditions like uveitis, IBD associated or Reiter syndrome, so they might have concomitant axial arthropathy changes. So these things should be kept in mind and it should not be missed. Thank you.
Thank you, Dr. Vishnu. Such a beautifully described the classification and the criteria and the radiological and the blood investigation that gives us a light to this topic about spondyloarthropathy. Now I invite the next speaker, Professor Alok Agrawal. Sir, I think so
Oh,
he has come.
Arti,
Or,
can we ask question to Vishnu? One question.
Okay.
Yes, sir. Yes, sir.
Yeah, Vishnu. So the cases which are not, the lesion which is not seen on the X-ray, out of the two, MRI and CT, which should be preferred?
Sir, CT has high specificity, sir. So it can easily detect structural lesions. So in sometimes even MRI can miss those findings, and other conditions where there is bone marrow edema conditions, we can lead to a false positive and we can consider it as axial spondyloarthropathy, sir. Because any bone marrow edema will be considered positive for axial conditions in MRI, sir. So it has a high false positive rate. But it is highly sensitive in picking up bone marrow conditions, edema.
No. Dr. Jha, sir, your comments on this?
Well, as far as the presence of findings in the X-ray is concerned, it will be too late a finding when the X-rays are showing positive changes. So the earliest we can get them is MRI. And at the same time, we have to be conscious of the fact that there is a class known as non-radiological spondyloarthropathy, where even in late stages, there will be no radiological changes.
Yes.
No, sir. No, sir. Out of the CT and MRI, which should be, preferred?
No, that he has very rightly said, that now it is imperative that even CT scan can be more specific. MRI can have some problems, can give you some problems in diagnosis, rather can misdiagnose.
Thank you, sir. Thank you. Sir, when we talk of non-radiographic, it means CT, MRI also, or only X-rays?
It is both.
It is both. Thank you. Thank you.
It takes minimum 5 years for the X-ray to show changes. So till 5 years, it will not show changes.
But
Thank you for enlightening us.
Dr. Vishnu,
Yeah.
Dr. Vishnu, you have said that two type of CT about the diagnosis of one is more sensitive and one is not.
No, sir. They were case examples, sir, where in X-ray you are not able to find out the.
I'm talking about CT only, not X-ray. X-ray is very late finding in the X-ray.
Yes, sir.
So it's a simple CT. Simple CT, you were saying that a simple CT is more sensitive than the MRI.
More specific, sir. MRI is more sensitive, sir.
No. Not Rameshwar is not said simple CT. He says low dose CT.
Low dose CT, sir.
And
Okay.
he is using two words, sensitivity and specificity.
Okay,
So
sir.
that way, that is more, CT is more sensitive,
CT is more sensitive. Low dose CT. Yes,
low
sir.
dose CT.
Low dose, yes. Okay,
Dr.
Arti.
Rameshwar is not visible?
Rameshwar.
Yes, sir. I'm little bit some
Okay,
some
okay, go ahead, please.
Thank you.
Any more questions from Dr. Vishnu?
Next speaker, please.
Professor Alok Agrawal from Raipur, AIMS. I think so. He has not joined.
So fellow
Doc-
is here. So fellow is here. He's going to present, I suppose.
Yes,
Dr.
yes, sir.
Ankit.
Yeah,
Dr.
Ankit will
Ankit is
present.
there.
Yeah.
Yeah, my screen is visible, sir.
Not yet. Share the screen.
Dr. Ankit is going to discuss about the disease
Yeah,
assessment
visible.
and the clinical features.
Good afternoon, sir. So I'll be speaking a brief presentation for disease manifestation and clinical manifestation for the various spondyloarthropathies. We have already discussed in details about the spondyloarthropathy as an entity which includes the inflammatory back pain, asymmetrical peripheral arthritis, enthesitis, dactylitis, and had got genetic predisposition with HLA-B27 and lot of extra articular manifestations. And the other classification system have been briefly explained by Professor Manish Khanna sir and Vishnu Senthil sir. So we'll be coming directly to the clinical features which are common to all the spondyloarthropathies. So there's a tendency for axial, spinal and sacroiliac inflammation. There's a asymmetric peripheral arthritis which is more common in the lower limbs than the upper limb, and most of them have an they are known as seronegative because they have absence of rheumatoid factor, and anti-CCP both are negative. The inflammation of enthesis is present. They have got lot of extra articular manifestations which includes uveitis in the eye, psoriasis, erythema nodosum, pyoderma gangrenosum, and genitourinary involvement, which we will be discussing specific to specific entity. When coming to the terms like enthesitis and peripheral arthritis, enthesitis is something which are the inflammation of the point where the tendons or ligaments attaches to the bone. It causes severe pain and tenderness, which is very relatively specific to the spondyloarthropathy. Most common sites, usually Achilles tendon, plantar fascia, epicondyles, lateral epicondyles are involved. And whereas peripheral arthritis is something which will be more commonly asymmetrical, and it will be ranging, the severity will be ranging from mild to disabling. And classical asymmetrical oligoarthritis, less than 3 joints, will be a very suggestive of spondyloarthropathy, but its absence is not be helpful to exclude its possibility. Dactylitis is something which is known as a sausage toe or finger, commonly found in the psoriatic arthritis and occasionally in reactive arthritis. So, unlike in the synovitis where the joint is swollen, in dactylitis the entire digit will be swollen. It is per se not specific for spondyloarthropathy because there are other conditions like tuberculosis, syphilis, sickle cell, even in tophaceous gout, it can be positive. And there are some extra articular manifestations which are also very common to all, which includes the uveitis, psoriasis, IBD, in which 10% of the patients will be affected. And we have discussed about the dactylitis and enthesitis. This slide have been already been discussed by Professor Manish Khanna sir, where he has included how we have to differentiate between the inflammatory and mechanical low back pain. With inflammatory have got an insidious onset, pain improves with an exercise, presence of morning stiffness, pain specifically at night, alternate buttocks pain, and the patient waking up in the second half of the night is the characteristic which is pointing towards the inflammatory back pain. And so when we look at the asymmetrical peripheral arthritis, this is a four diagram where we can see in the patient of rheumatoid arthritis where all the joints are affected usually in a symmetrical fashion, with affecting the metacarpophalangeal joint, proximal interpharyngeal joint, metatarsophalangeal joint. Whereas when we look for a patient with a psoriatic arthritis, typically PIP and DIP, post proximal interphalangeal and distal interphalangeal joint, will be involved and will be in asymmetrical fashion. Similarly, for when we look for a patient with an angstpond, we see most of the axial spine will be involved, whether the back, sacroiliac joints, hip, knee will be involved. And obviously in osteoarthritis, the other joints like DIP, base of thumb, they are more commonly involved. And this is site and distribution of common arthritis, usually for the hand and foot. We can see the rheumatoid arthritis, there will be relative sparing of the DIP joints with involvement of more metacarpophalangeal and proximal interphalangeal. Similarly, for psoriatic, there will be sparing of the metacarpophalangeal joints and gout involvement and CPD associated pseudo gout involvement, both for the hand and foot disease. So coming to the specific entity and the manifestation, we have the ankylosing spondylitis, which is known as the inflammatory disorder of spine, which has got a bilateral sacroiliitis characterized by fusion of spine in an ascending manner, usually at the lumbocervical direction, with secondary low back pain and stiffness. Characteristically worse in the morning, improves with activity, and worsen with rest. There will be gradual loss of lumbar lordosis, increased kyphosis, ultimately leading to a chin vertebral deformity and chin to chest deformity, sorry. And it's a progressive disease which can lead to deformity over time. So when we have a look for the classification criteria for axial spondyloarthropathy, so patient should have a more than 3-month back pain, age of onset should be less than 45 years, and we have to distinguish whether we have a sacroiliitis on the imaging, which already Dr. Vishnu sir has told about the New York criteria, and MRI finding and low grade CT also, and with along with one spondyloarthropathy feature, which includes the arthritis, enthesitis, uveitis, dactylitis, and so on. While the other criteria can be HLA-B27 positive and 2 other spondyloarthropathy features. And this criteria has got a relative sensitivity of around 82% with specificity of around 84% to diagnose the axial spondyloarthritis. There are other extra-articular manifestations, specifically in angstpond, like for eye involvement, there will be uveitis leading to decrease in visual acuity and eye pain. GI, usually it's asymptomatic. Cardiac, it can be associated aortic regurgitation, conduction abnormalities. Renal, it can be due to increased deposition of acute phase reactant proteins and secondary amyloidosis. Respiratory atypical lung fibrosis may be there due to inflammation of the lung interstitial tissue. And coming to the next disease, which is like psoriatic arthritis, it is common in patients usually with psoriasis, and it occurs in up to 30% of patients with psoriasis over the time. Although most patient will have around 70% will have some form of cutaneous manifestation at the time of presentation, but in 10 to 15% arthritis precedes the skin disease, and for them we have a specific terminology known as psoriatic arthritis sign psoriasis. And these patients generally presents with a joint pain, stiffness, same lasting for more than 30 minutes, and it involves both the axial joints and the peripheral joints are commonly involved. There is a clinical pattern which was described for psoriatic arthropathy by Malls and co-workers, where they have distinguished various patterns of arthritis, and they have estimated the incidences. Like asymmetric oligoarticular or monoarticular can happen in 70%. Symmetrical polyarthritis can happen in 5 to 20%, and if it is there, it is associated with poor prognosis. Distal interphalangeal joint predominant arthritis can be there in 5 to 10%. Arthritis mutilans can be there in 5%, and axial predominant disease can be there in up to 50%, may be associated with HLA-B27 gene, and 2 to 4% without association with HLA-B27 gene. So unlike in patients with rheumatoid arthritis, most patients present with distal interphalangeal joint involvement, asymmetrical monoarticular involvement. Dactylitis is usually common in 30 to 40% of patients, and most commonly in the third and fourth toes. Enthesitis and tenosynovitis can occur up to 40%, and the commonly it involves the Achilles insertion and the plantar fascia. So these patients should be frequently screened for early signs of musculoskeletal disease and presence of scalp lesion, nail dystrophy, intergluteal or perianal disease, and obesity are the patient associated with increased risk of psoriatic arthropathy. And delay in diagnosis can definitely have a risk for erosive disease and sacroiliitis. So we are here showing the images of the varial nail abnormality. A, we can see the pitting changes in the psoriatic arthropathy. This is the leukonychia changes. Splinter hemorrhages are there, and definitely subungual hyperkeratosis, which are all spectrum of the psoriatic arthritic nail abnormalities, which is shown in the slide. This is the example of the sausage disease where there's a diffuse swelling of the index and the ring finger, and the skin is typical, also showing changes for the psoriasis. So there is a classification for psoriatic arthritis. We have a Casper criteria. To meet this criteria, a patient must have an inflammatory articular disease, and a score of more than 3 points are based on the criteria of base of evidence of psoriasis, presence of nail changes, negative test for rheumatoid factor, presence of dactylitis, and radiological evidence of new bone formation, juxta-articular new bone formation. So this was given in 2006. There are clinical variants for psoriatic arthropathy, which we have discussed previously, which involves the asymmetrical, symmetrical, and distal interphalangeal synovitis. So most of these patients have an equal gender distribution and characteristic. They are between 20 to 40 years of onset. So there are phenotypic differences when we look for angst and we look for the alternative phenotype like psoriatic arthropathy. So when we look at individual places, like for cervical, there's a more frequent cervical involvement in psoriatic arthropathy, more frequent fusion of facet joints. When we look for thoracolumbar involvement, presence of marginal syndesmophytes with symmetricals and uh, more frequent fusion involves bamboo spine will be there for angst, while non-marginal and paravertebral ossifications may be suggestive of psoriatic phenotype. HLA-B27 can be positive in up to 90% of cases in angst, whereas for psoriatic phenotype, it can be up to 19 to 40%. There are clinical manifestation like for psoriatic, there will be low frequency of the inflammatory back pain, usually will be an older age of presentation, and will have a more peripheral presentation rather than the axial presentation. The same portion where we have included the treatment response, where usually in ankylosing spondylitis, the NSAIDs and inhibitors are more responsive. And for other, we have other treatment response, which we'll be discussing in the subsequent presentations. For reactive arthritis, it's basically as a sterile synovitis which occurs secondary to post gastrointestinal infection with Shigella, Salmonella, or any other E. coli, or even with a sexually acquired infection in which a non-specific urethritis is there for male, or cervicitis is there for female, or with chlamydia infection. So it's basically an immune reaction to infection, to whether of a GI tract or a urinary tract. Since it's an immune reaction, usually antibiotics are not used. And from the time of infection, this reaction usually takes 2 weeks to mount. Sometimes it can occur up to month also. 2 to 4 weeks is usually the time which precedes the onset of the arthritis for the patient. The typical feature will be a young man who will be coming for an acute arthritis within an episode of an enteric or a sexually acquired infection. The joints of lower limb, particularly the knees, ankles or feet will be affected, usually in asymmetrical pattern, and at least one of the following will be seen, like asymmetrical oligoarthritis, enthesitis, dactylitis, and back pain will be there. So there is a classical triad which is described, which conjunctivitis can't see, can't pee, and can't bend the knee. But the classical trial is usually less commonly seen, and most of the patient does not present with the classical findings of readers in this. There are some additional features like enthesitis, acute uveitis, and few patients, obviously around 5% patient develop sacroiliitis and spondylitis also. So there are some skin lesions will be resembling to psoriasis. And there's a keratoderma blenoregica, which is a red plaque and pustule which resembles the pustular psoriasis. It can be commonly found in the palm and soles of the patient. Superficial ulcers like Sarcinate balantis can be there along the penile meatus. Nail dystrophy changes can be also present. So it has got a major criteria and a minor criteria, and the definition includes both major criteria if present or a relevant minor criteria will be there. So it's a definitive diagnosis, probable diagnosis, both with no minor criteria or major criteria with one or more minor criteria. So among the major criteria, we have the asymmetrical arthritis, monoarticular, which predominantly affects the lower limb, and a preceding symptomatic infection, whether an enteritis or a urethritis. Among the minor criteria, we have an evidence of triggering infection, whether will be positive nucleic acid NAT test for either chlamydia or stool culture for enteric pathogens. And we have an evidence of persistent synovial infection, maybe for a PCR for chlamydia or immunohistology. So when we look at the next form of spondyloarthropathy, we have enteropathic arthritis. It's basically an inflammatory bowel disease, specifically Crohn's or ulcerative colitis mediated, which are commonly associated with an extraintestinal manifestation. Musculoskeletal complications are usually common, and there are various risk factors, which includes an active bowel disease, a family history of IBD, appendectomy, cigarette smoking, and presence of some additional extraintestinal manifestations. There are two types broadly classified: type 1, type 2. Type 1, which is more common in the Crohn's disease, around 4 to 5%, in which less than 5 joints will be involved. Mostly the large joints will be involved. In type 2, usually the small joints are involved, and there will be it is based on the erosion destruction, which is most commonly in the type 2 joints. And it is usually type 1 is parallel with the activity of the disease activity, and whereas type 2 is independent of the activity. And HLA-B27 association is usually common in type 1 type of polyarticular. Type 2 usually have association with HLA-B44, and the treatment involves the same control of the activity, COXIPs, and use of DMARDs like sulfasalazines for and other biologicals for the refractive cases. So when we look for the juvenile onset spondyloarthritis, which is the last type, where usually it's distinct to the adult spondyloarthropathy because it constitutes to the 1/3 of the pathology, and usually affects the male, starts in early onset before the age of 16. And there's a criteria which and this disease primarily affects the children fulfilling the criteria for JIA, for enthesitis related arthritis and juvenile psoriatic arthritis. Tender entheses are commonly present at the insertion of patellar ligament at inferior patella, plantar fascia, and Achilles tendon. So it is also possible that most of the patients may have recurrent fever, eye pain, redness, irritability, skin rashes, joint swelling, and appetite loss along as a symptom for juvenile arthritis. And there are various type basis on the juvenile idiopathic arthritis. One is the systemic type, which includes the affects the whole body. Oligoarthritis, which affects usually 4 or less joints. Polyarticular, which includes the swelling or pain in the 5 or more joints. Polyarticular positive, which behaves like an adult rheumatoid arthritic. Psoriatic negative, enthesitis related, and undifferentiated, which does not fit on any of the criteria. So what is common for all? We have to go for lifestyle changes for all, like regular physical activity, balanced diet, and alcohol and limit alcohol and manage stress. The primary goal for all of the patient for evaluation is to relieve the patient of symptoms, maintenance of functions, prevention of complication of spinal disease, and minimize the extra-articular manifestations. So how we will evaluate and monitor this patient? The response to therapies are usually some of the agents are very tremendous, and it varies from patient to patient. For all the patients, we have to regularly monitor the disease activity and medication safety. Like for NSAIDs, we have to evaluate the patient every 2 to 4 weeks, then on a monthly basis, and every 3 monthly basis when stable or once we are starting the biological agent. when we are using something as tumor necrosis factor inhibitor or interleukin 17 therapy, we have to evaluate at least after 12 weeks, and the subsequent monitoring can be there up to 3 to 6 weeks when the disease is under control. So the frequency of visit and laboratory assessment definitely depends on the patient's response to therapy and the medications which we are using. Imaging should only be repeated when the results might alter the treatment strategy. Like if we don't have, for a patient with axial spondyloarthropathy, repeating an MRI won't be changing much of our treatment strategy. So there's no point in repeating them again and again. And clinical assessment should be include focus history examination and look for other features screening for axial spondyloarthropathy. So there are disease activity assessment charts, like for ankylosing spondylitis we have BASDI index, which an instrument which we use for assessment of disease activity in a questionnaire format, and score of more than 4 is an indicative of active disease which warrants consideration for a biological therapy. And clinical improvement is defined as 50% improvement of the score on absolute change of more than 2, or a clinical expert opinion that the patient has improved. So this is the example of a BASDI scores. These scores are readily available in the internet, in UpToDate and other websites, and we have to evaluate the patients in each visit. We have to subsequently evaluate the patients whether of the score, and we have to score them, and then we can monitor them. Similarly, there's an ASDA score which has got all the questionnaires from BASDI, and they also incorporates the level of acute phase reactants in addition to the clinical parameters. So it is considered to be better than BASDI, and it characterizes the disease basically into inactive, low, high, or very high. And based on the disease activity, we have to consider for the biological therapy. The score is also available online, where easily available online, where we can have to calculate for all the patient back pain as per the BASDI questionnaires, peripheral pain, duration of stiffness, presence means value of CRP, ESR, and then it will give up the score, final score, from which we have to decide whether it's a clinical improvement is there or not, or the disease activity is very high, or we should consider for alternate therapy. So we should individualize the over the course of therapy. We should individualize each and every patient. Take use of serial quantitative measures like ESR, CRP. Score the patient using the scores, various scores parameters which we have, so as to help in the serial monitoring of the patient. At last, arthritis is a battle which never ends, but we have to keep on fighting. And I thank you all for giving me the opportunity to speak on this forum with such legends. Thank you, sir.
Thank you, Dr. Ankit. Dr. Alok has joined, I think so. Any questions
Yes,
from Dr.
madam.
Alok? Dr. Alok, are you there?
Yes, madam.
Okay. Any questions from the house?
Arti, maybe at the end we continue with the lectures.
Okay, sir. Okay, sir. Now, next speaker, I'll invite Professor Sanjay Keshkar, the Director, Professor and Dean from Kolkata Medical College, Editor, International Journal of Orthopedic Surgery, Associate Editor, International Journal of Orthopaedic Rheumatology, and an Associate Editor, Indian Journal of Orthopedics. He's going to talk about other spondyloarthropathies, the reactive, enteropathic juvenile, and undifferentiated spondyloarthropathies. Dr. Sanjay Keshkar, please. Are you there, sir?
Yes, ma'am. So, is it my slide is visible?
Yes, sir.
Yes. So, thank you, Dr. Arti, for introduction. So, my talk is on other varieties of spondyloarthropathy, that is reactive, enteropathic, juvenile, undifferentiated. So, Dr. Ankit has made my lecture easy because he has already covered most of it. So I will just run through my slides. So as we all know, that spondyloarthritis is a spectrum of immune-mediated inflammatory diseases with overlapping features. Spondyloarthropathy frequently involves the axial skeleton and can result in abnormal bone formation with ankylosis of spine, which causes substantial disability. As far as classification is concerned, so far with previous lectures, we can divide it we can classify into different ways, like seropositive if RF factor and anti-CP is positive, and seronegative if it is negative. Juvenile and adult variety of spondyloarthritis, if the person is less than 16 years, then usually we call it juvenile spondyloarthropathy, and more than that, adult spondyloarthropathy, which is commonly known as spondyloarthropathy. Depending upon the involvement, if it is involving the spine and sacroiliac joint, axial variety, and peripheral means the lower limb or the upper limb joints are involved, and some other forms depending upon the association with the different diseases. Like these are the varieties you can see. The majority goes to the ankylosing spondylitis. Other than that, it can be acute anterior uveitis, reactive arthritis, arthritis associated with colitis or the Crohn's disease, then juvenile variety, and then undifferentiated variety and psoriatic arthritis. So I'm not going to cover ankylosing spondylitis. Other than that, we have 4-5 varieties, which I am going to cover one by one. So enteropathic arthritis associated with ulcerative colitis and Crohn's disease. Most common extraintestinal manifestation of intestinal inflammatory bowel disease with significant morbidity. Both ankylosing spondylitis and peripheral arthritis features are seen, but usually it starts with the peripheral arthritis, then progressing to the sacroiliitis, and in the severe stage, it is involving the axial variety of spondyloarthropathy. Then, according to 1998 Oxford criteria, it can be divided into 3 types. Type 1, and that is the type 1 enteropathic arthritis, that is basically the oleo-articular disease paralleling bowel inflammation and usually self-limiting. In type 2 variety, it is a chronic symmetric polyarticular disease independent of bowel involvement. In type 3, axial and peripheral joint involvement there. So etiology, there are aggravating factors like HLA-B27 found in 70% of patients of inflammatory bowel disease and ankylosing spondylitis, but in less than 15% of patients with only the inflammatory bowel disease and peripheral arthritis. So this is the difference. If inflammatory bowel disease is associated with ankylosing spondylitis, then 70% people will be having HLA-B27 positive. However, if it is associated with peripheral, then only the less than 15% patients will be having HLA-B27 positive. And this endoplasmic reticulum aminopeptidase 1 and 2 are also the aggravating factor, and interleukin 23 and helper T17. So they are the causing the dysbiosis of the local gut microbiota and leading to the enteropathic spondyloarthropathy. Clinical features is discussed earlier also. Axial involvement includes back pain and isolated sacroiliitis arthralgia, morning stiffness at joints, enthesitis, dactylitis, abdominal discomfort, anterior uveitis, and erythema nodosum. Diagnosis is done clinically when a patient is suspected with inflammatory bowel disease and joint pain. Laboratory test, non-specific but raised CRP and ESR may be seen. X-ray of spine and sacroiliatic joints, but in early stage it is not possible to see any features, and in that case MRI with start tau inversion recovery is gold standard. As far as treatment is concerned, NSAIDs, the choice of drug is COX-2 inhibitors, then systemic glucocorticoids, DMRDs, and then finally in the severe cases one can go for the TNF alpha blockers like infliximab, adalimumab, etc. Prognosis associated with significant morbidity, more in females and in smokers. Complications can be obstruction, strictures, fistula, pathological features, fractures, spinal deformities, cardiovascular complications, so forth and so on. Now coming to the next variety, that is the reactive arthritis. It is a non-purulent arthritis complicating an infection anywhere in the body. Here also HLA-B27 is the main culprit. The people having HLA-B27 positive are more prone for this kind of reactive arthritis, and infectious agents like Salmonella, Shigella, Yersinia, Clostridium, and E. coli. Clinical presentation include asymmetric lower limb oligoarthritis, conjunctivitis, dysuria, chronic heel pain, low back pain, and this kind of arthritis persists for 3 to 5 months but can extend up to 1 year. These are the clinical pictures already shown by the Dr. Ankit. So here the endomethacin is the choice of drug, first choice, 75 to 150 milligram. Then one can go for methotrexate, sulfasalazine, erythromycin, and then the antibiotics given to control pyuria and other infection. Next variety is juvenile spondyloarthropathy. It is a distinct form of juvenile arthritis characterized by male predominance and adolescent onset. Clinical manifestations include lower extremity and sacroiliac joint arthritis, enthesitis, and subclinical gastrointestinal inflammation. So ELAR categories are there for this juvenile spondyloarthropathy, and basically they divided into 3 groups: enthesitis related arthritis, psoriatic arthritis, and undifferentiated arthritis. And some other classifications are also there. There are n number of classifications, but ELAR criteria is accepted one. So out of these 3 varieties, the enthesitis related arthritis is the most common, which we are going to discuss. So this is the arthritis and our enthesitis with at least 2 of the following. One is the sacroiliac joint tenderness or inflammatory spinal pain, presence of HLA-B27, onset of arthritis in a male over 6 years of age, family history, and at least 1 first-degree relative of ankylosing spondylitis, ERA, sacroiliitis with IBD, reactive arthritis, or AAU, acute anterior uveitis. But exclusion, psoriasis or history of psoriasis in the patients are first-degree relative, presence of IgM, RF on at least 2 occasions, at least 3 months, systemic JIA in the patient. So these are the exclusion criteria for juvenile spondyloarthropathy. As far as diagnosis is concerned, radiographs remain the gold standard for diagnosis of juvenile spondyloarthropathy. However, it is well established that radiographs are insensitive for the detection of early sacroiliitis, and hence bone marrow edema on magnetic resonance imaging is visible prior to radiographic changes and is one of the accepted imaging modalities. These are the various treatment modalities. They have divided into 2 groups, this according to the American College of Rheumatology. The people have the adolescent or the juvenile patient having involvement of 4 or less than 4 joints, they have this kind of modality of treatment starting from NSAID to TNF alpha blocker, and for 5 or more than 5 joints, again they have different kind of programming for the medical treatment. Now coming to the undifferentiated arthritis, this is the arthritis that fulfills none of the ELAR categories or fulfills criteria in 2 or more than 2 categories. They can be labeled as undifferentiated spondyloarthropathy. So general consideration, undifferentiated arthritis is a common inflammatory form of arthritis involving joint swelling, pain, and stiffness that cannot be classified as rheumatological disorder. There is lower joint count and less hand involvement. Here the lower joints are more involved as compared to the upper limb joints. So an estimated 45% to 55% of patients will achieve spontaneous remission, whereas up to 32% go on to develop rheumatoid arthritis. So this is the most important feature. If you don't treat it in early stage, 32% of them might go into develop rheumatoid arthritis. Early treatment affords the best chance of preventing disease progression, disability, and decreased quality of life among those at risk of developing rheumatoid arthritis. So goals of treatment: to control the symptoms, whatever symptom is there that needs to be controlled, and to stop the progression of undifferentiated arthritis to progress to rheumatoid arthritis. So treating undifferentiated arthritis before it progresses to rheumatoid arthritis is very, very important. Patients with polyarthritis may be treated with methotrexate or leflunomide, and a patient with oligoarthritis may be treated with sulfasalazine or hydroxychloroquine. Administration of single injection of 120 mg of methylprednisolone has been suggested as a useful approach as a bridging therapy to induce remission in this patient. So before I end, I have brought this X-ray. 4 X-ray pictures are there. The extreme left is of spine, involvement of spine in rheumatoid arthritis. You can see reduction of disc space between here, and then slight listhesis you can see. This is the in severe stage, the bamboo spine. You can see typical classical picture of ankylosing spondylitis. This is the picture of psoriatic spondyloarthropathy, where you can see the syndesmophyte, both side alternating variety. And this is of Richter's disease. You can see occasional syndesmophyte, and that is the far away from the ear. So with this, I end my lecture. Thank you very much for patient hearing.
Thank you, Dr. Keshkar. Now, I'm blessed to invite Professor Jha, Founder Advisor, Indian Orthopaedic Rheumatology Association, to talk on guidelines of management of spondyloarthropathy. Sir?
Right, thank you.
Dr. Alok sir, please mute. Thank you.
No, something is wrong. All right. My computer is giving problems. I'm not able to see. Oh, no. Can you see it now?
Yes, sir.
Right. Today, there were some teething problems. Friends, thank you very much. Well, today I'm going to speak about guidelines for management of spondyloarthropathy, which are also our IORA and IOA guidelines. All of us by now are familiar with this presentation, in which it is not one disease, is a conglomeration of various diseases, and ankylosing spondylitis is in the center. So why do we want to treat, or why have we been talking about so much? Because we are able to make a diagnosis, and after making a diagnosis, the goal of treatment is 1, maintain quality of life, 2, control symptoms and inflammation, and 3, that treatment will be the best which can prevent structural damage, but it is better said than done. So the goal of treatment, what is the current scenario and what is the dilemma? So 2016 update by SAS or EULAR guidelines for axial spondyloarthropathy, they recommended that treatment should be guided according to a predefined target, but controversies are still there that this target should be and when should we intervene. Individualized treatment is the future by identifying biomarkers of response and various prognostic factors. Treat to target strategies will ensure early review of patient with brisk escalation of treatment to switch off the aberrant immune inflammatory process. The currently available treatment options are: number one, use of non-steroidal anti-inflammatory drugs, and they are the first line therapy in case of ankylosing spondylitis. So main therapy areas are pain relief and suppression of inflammation. The treatment goal should focus on the potential, not acceleration, deceleration, and the arrest of structural damage. They are controversial, but generally accepted that NSAID should be administered continuously in terms of disease progression. Now look at this slide. When we are going to give NSAID, there are three focus areas. Symptom control, yes, NSAID can provide. Functional improvement, it will provide. But stopping or slowing by radiographic progression is least. There are some evidences, but not full proof. So, as far as the biologic is concerned, treatment of ankylosing spondylitis and psoriatic arthritis has gone revolutionary change with biologic agents. The biologic target specific aspects of the immune system, avoiding other end organ toxicity. They have expanded our ability to control ankylosing and spondyloarthropathy. Now look at the same presentation once again. If it is biologic, the use of biologic has satisfactory evidence-based symptom control and functional improvement, and also has a growing body of evidence for its long-term use in slowing or stopping radiographic progression. Now, these are the various classes of biologics, and that the cytokines can be blocked by them. So we can identify especially IL-17, TNF-alpha. So what are the mechanism of action of the biologics? So TNF-alpha blockers, all of us are familiar, are etanercept, infliximab, adalimumab, golimumab, certolizumab. IL-17, they have come in the last decade, and secukinumab is very prominently used. Brodalumab and ixekizumab is also another. Ustekinumab is another. IL-12 and 23 blockers are also now available in the market by the name of tildakinumab and guselkumab. Well, what is the dose and route of administration? As you will notice, all of them can be given subcutaneously except infliximab, which has to be given intravenous. Etanercept is 50 milligram weekly. Adalimumab has day 1, 40 milligram, and then keep on repeating it every fortnightly. Infliximab 5 milligram is standard dose, which should be given at 0, 2, and 6 weeks, and thereafter every 8 weeks. Secukinumab can be given 150 milligram at week 0, 1, 2, 3, 4, and monthly thereafter. Golimumab is 50 milligram monthly. Well, secukinumab can also be given in a higher dose, that is 300 milligram at weeks 0, 1, 2, 3, and then 4 monthly thereafter. So both 150 and 300 milligram dose for secukinumab is there. Well, investigations naturally, before putting your patient on biologic, you have to satisfy yourself that the patient does not have any infection from before, so that the after use of TNF alpha, the patients do not get another infection, mostly tuberculosis. So you investigate, and at the same time you have to see that if you are treating a patient, the patient is not pregnant as well. Well, so let's talk about who are the best candidates for biologics. Number one, patients for whom conventional therapy with non-steroidal anti-inflammatory drugs have failed. When two different NSAIDs are not much effective and helping the patient. NSAID causing stomach problems or other medical conditions, and patient still have high pain and stiffness. Disease having a big impact on patient's life or might be affecting work, family life, etc. Most importantly, the ideal candidate is one who is not responding or who has failed with the first line of conventional synthetic DMARDs. So let's talk about 2016 EULAR update. So they talk about 13 management recommendations for treating these patients. Number one, the treatment has to be individualized depending on the presence of comorbidities and psychosocial factors. I will also add economic factors. Then second one is, how do we monitor the patient? And this monitoring should always include reported outcomes, clinical findings, lab test, imaging, all with appropriate instruments and relevant to clinical presentation. 3, treatment should be guided according to a predefined treatment target. Number 4, education of the patient becomes so very important, in which exercise has a role. The smoking must have been stopped, including alcohol as well, and physical therapy has to be a prime consideration. Patients suffering from pain and stiffness should use NSAID as first-line drug. Analgesics such as paracetamol and opioid drugs might be considered for residual pain. Glucocorticoid injection directed to local site of musculoskeletal inflammation may be considered. Patient with axial disease should not receive long-term treatment with systemic glucocorticoids. Patient with purely axial disease should normally not be treated with conventional synthetic DMARDs. Sulfasalazine may be considered in patients with associated peripheral arthritis. Biological DMARDs should be considered in patients with persistently high disease activity despite conventional treatments. Current practice is to start managing these patients with TNF-alpha inhibitor therapy. Now, if TNF-alpha inhibitor therapy fails, switch over to another TNF-alpha or an anti-IL-17 therapy. If a patient is in sustained remission, taper off the biological DMARD. Total hip arthroplasty or spinal corrective deformities can be undertaken as a surgical management, and if a significant change in the course of the disease occurs, causes other than inflammation, such as a spinal fracture, it will have to be diagnosed, appropriately evaluated, including imaging. So let's come back again, if we can tell guideline number 1, diagnosis. So history is, with history, suspect spondyloarthropathy, as all of you have enumerated earlier, patient with 3 or more months of chronic back pain and age of onset less than 45. So then requisition specialized investigation. We have been discussing about it. Obtain MRI of the sacroiliac joint, which detects active inflammation of the sacroiliac. and HLA-B27. Guideline number 2, ascertain whether this disease is axial spondyloarthropathy or peripheral spondyloarthropathy. Number 3, determine the disease activity, whether it is active or stable. Active is one where symptoms is at an unacceptably bothersome level, and inflammatory it is as per clinician's judgment. Stable ankylosing spondylitis is asymptomatic disease or symptoms at an acceptable level. And number 3 is so important that the patient will be clinically stable and minimum 6 months of therapy is required to make these patients stable. Well, number 4 guideline, initiation of your therapy. So first line therapy, as I have already told you, should be NSAID. Now, how do we give 2 NSAID? Continuous 2 NSAIDs for 4 weeks. That means either give the first one for 1 week and then the other one for 3 weeks, or the first one also for 2 weeks and the second one also for 2 weeks in full therapeutic dose. There is no preference. You can have your own individual experience to use them. Well, as far as systemic glucocorticoid is concerned, its role in management of spondyloarthropathy is not to the extent as it is in rheumatoid. Peripheral arthritis patient, do give sulfasalazine and prefer it over methotrexate. The first line therapy as first line therapy. Well, local glucocorticoid infiltration also has been mentioned, that if 2 or less than 2 joints, peripheral joints are involved, glucocorticoid can be given. It can also be given in isolated sacroiliitis, but do not use it in enthesitis areas, and physiotherapy is a must. Guideline number 5 is active disease despite NSAIDs. So now comes the stage of second line therapy. What is the first choice? Any TNF-alpha inhibitor, no preference. Second choice is secukinumab or ixazumab. Third choice is tofacitinib. Now, this third choice of tofacitinib can be promoted to a second choice as well, and many a times it could be the first choice also, because now FDA has recommended its use. For ankylosing spondylitis, IBD or uveitis, prefer monoclonal antibodies like infliximab, adalimumab, certolizumab, golimumab over other biologics. Guideline number 6, when you have treated your patient to this stage, stop, look, and then only go. If there is no proper relief on the biologic that you have given, doubt your diagnosis, further investigate your patient, and maybe this is another time when you prescribe either a spinal or pelvic MRI. Guideline number 6, it is further confirmed that this patient is an active ankylosing spondylitis but is not responding to first or second line, then the third line becomes imperative. And the first degree non-responder and second degree non-responder, they are the 2 types. So the first degree non-responder, despite using TNF-alpha, the first strong choice is secukinumab, and here see, second choice becomes tofacitinib. The second degree non-responder, despite TNF-alpha use, is another alternative TNF-alpha. Guideline number 8, now you have treated your patients and patients are now stable. As I told you, that it will take minimum 6 months. So physical therapy has to be instituted, but do not send them to a regular physiotherapist. Unsupervised back exercise, which can be performed maybe in a formal group or individual self-management education. The second one becomes important also, that when the patients are stable on biologic, do not discontinue or taper very abruptly. So what we do, NSAIDs can be given on demand. Stable patients on TNF alpha plus NSAID, now you can withdraw the NSAID. Stable patients on TNF alpha plus oral TS-DMARD targeted synthetic, that means tofacitinib, continue TNF alpha alone and stop TS-DMARD. Now I would like to say that you can reverse the trend. You continue with TS-DMARD and can stop TNF alpha. Friends, we are using biosimilars. So if you are using biosimilar of one company, do not interchange with the same biosimilar from another company. Guideline number 9. General management at all stages. Monitor using validated AS disease activity measures, about which the previous presenter has said, like CRP, ESR. Avoid using treat to target strategy with target of S-score less than 1.3 or 2.1 over strategy based on provider assessment. Avoid repeated spine radiographs at a scheduled interval. Never keep on prescribing radiograph at every checkup. Avoid obtaining spinal or pelvis MRI to confirm inactivity. Guideline number 10, when deformity, osteoporosis and arthritis, they have supervened, you can go for either a total hip arthroplasty or perform a spinal osteotomy in a specialized center, but never go for spinal manipulation. You might produce a fracture. Guideline number 1 regarding traditional DMARDs recommends using traditional DMARDs de novo in higher doses or following biological therapies whenever cost is a constraint. So sulfasalazine, though otherwise has potent anti-inflammatory effect, is similar to NSAIDs and also has antibacterial and immunomodulator properties. Well, in psoriatic arthritis, higher doses of methotrexate are more effective and results are comparable to rheumatoid arthritis. Remission is achievable in 20% of psoriatic arthritis. Thank you very much, and I leave you to the summary of the guidelines which I have already enumerated. Thanks.
Thank you, Dr. Jha, for enlightening us on this special topic, spondyloarthropathy, from A to Z. Now, it's open for discussion. Any questions from the faculty, from the panelists?
Well, to start the discussion, I will like to say that management is not very difficult. But what is our duty as a clinician on day one when a patient has been seen by you the very first day? You must provide full confidence. So the interaction becomes very important. The first time is the best time to tell them. Somebody said in the end, arthritis is a lifelong treatment. So you have to tell your patients that do not stop the therapy when you have found clinical relief, because the disease is bound to come back. So this, I feel, is the first important duty, to make them understand that the disease may not get cured, but will definitely get control. And to get this control, giving good clinical end results, they must continue with the medicines. Right, Arti?
I think Arti has left.
Okay. Well, I also remember one thing. Dr. Alok, will you remember your accordion treatment.
Yes, sir. That I was doing for osteoporosis.
Right. Now, so here also, now people say it may not be an accordion, but your dose should be reduced. Like
Okay.
I will say, in my own experience, I have been talking about the classical conventional dose of etanercept. 50 milligram once weekly is the classical dose, right? Here, because our Indian patient's body weight is on the lesser side as compared to the Western world, so all the Asian population, even 50% of the dose is sufficient. Now I have treated more than 2,000 patients with only 25 milligram etanercept weekly, and they have all been successful. I have also published results. So I would recommend that wherever feasible, maybe 50% of the dose also will suffice.
So we were monitoring our patients with CRP and ESR, but we found that gradually over 7 years, 8 years, the spinal deformity was increasing. So now after today's CME, I will be using SDAS also along with CRP and ESR. That's how I feel.
Yes. You will see that S-DAS, for that matter, has to be calculated with the CRP or with ESR. So they are so named.
Yes. Thank you, sir.
Sir, I have one question, Dr. Jha.
Yes.
Sir,
Keshkar.
not question, but
Yes, discussion.
just a discussion.
Right, sure.
Some patients are coming to us, and we are using biologics on those cases. And particularly in my center, because its treatment is free. So initially, say for example, one patient we started secukinumab, and after some time, what happened is that facility, that free facility, his card left.
Right. Yeah.
So in those cases, though, and sometimes even in a state government, so many facilities has come up, particularly in Bengal, that Swastha Sati was there earlier, but suddenly since last 2 months, it is not there. So those patients are suffering. So those patients are suffering a lot. So how to modify their treatment? That is the big issue.
So I have already said, where cost is a constraint, you can still fall back on the conventional synthetic DMARD, especially sulfasalazine, maybe in a higher dose. Sulfasalazine, what is their dose? Normally we use up to 2 grams. You can start from 500 milligram, gradually increase to 1 and then to 2. But sometimes do not restrict yourself to up to only 2. It can be used up to 4 grams. So higher doses of sulfasalazine, as I have said, they are not only anti-inflammatory, they also work as antibiotics. And most importantly, you have just said that it is the gut microbiome which are so very important. So that way also sulfasalazine becomes very important. And whenever peripheral arthritis is associated, sulfasalazine definitely works there. Methotrexate also works there, but not so much in spondyloarthropathy as it is the gold standard one in rheumatoid arthritis.
Right.
Dr.
I think
Mukherjee,
most informative talk, sir. Very informative talk, sir.
So, regarding the use of a steroid, once again, rheumatoid and spondyloarthropathy, they differ. Local glucocorticoid injections definitely helps, and we should not hesitate in putting our intra-articular injection into the sacroiliac joint, only that it could be guided maybe with the help of ultrasound or a CT scan. But systemic use, long continued use is not recommended. Shorter pulse doses can be given in spondyloarthritis as well. As far as NSAID is concerned, 4 weeks is the initial dose in which NSAID should be continued, 2 weeks or 3 weeks. But there will be a stage when it has started giving you complications like gastric irritability, or maybe the kidney is not so friendly and you have to stop it. So these are patients, if they can afford, we can switch over to TNF-alpha inhibitors.
Sir, if patient is feeling no problem with long-term NSAIDs.
Yes, you can
It's
continue
given,
it for a
then-
very
then-
long term.
Okay. So we can continue it for a long time.
That is the reason phenylbutazone though is now not available in most of the markets, but still it is available, and phenylbutazone is the recommended drug, or indomethacin is the recommended drug. So yes.
But nowadays, sir, etoricoxib is most acceptable, I think, and my patient is very comfortable with this one for
Yes,
8 months.
Right.
Sir, indomethacin, what is the maximum dose you can go for a young adult, sir?
75 milligram, we should not exceed
Daily.
So there are SR tablet available.
Yes, sir.
You
Yes.
can give them only once.
Yes.
And that can be given.
So Dr. Arti got disconnected due to some technical problem. So
Okay.
I think, is there any other question from the forum? From that
And
side?
Dr. Rajesh Gupta, he himself is not here.
No, he has left, I think, sir.
He left, sir. He has another meeting, AO meeting.
Oh, yes.
So he has to switch over to that side.
Right.
So Arti is not there and Dr. Rajesh there. But Arti is because of the technical glitch, and Dr. Rajesh Gupta has gone for other meeting. So I think, sir,
we can have some comments from Amitabh.
No, sir, this was very informative meeting after. Just I wanted to say one thing, sir, that we can compile this whole meetings, and we can put it on a soft copy mode, so that can be really be useful for lot of our members. Like these meetings or webinars, what we have come across. So you decide, sir, you talk to everyone if these lectures can be given to the
Yes, you are very much right. These lectures are all available on YouTube.
Yes,
Right,
sir.
sir.
And IOA TV also, it is recorded.
Right.
No, sir. I know that. I am not saying that.
Right.
What I wanted to say, sir,
it's a separate collection of them.
A separate collection of soft tissue. Soft tissue. What I said, soft copy in a library form. Chinmoy, কি কইলাম বুঝছো? যে কেউ খুলতে পারবে। Like sir, here you can scroll, or this, like if you can give it like this PPT format even also, maybe the way you cannot change it, but people can see and it is easy to go through.
Yes, sir. Yes, sir. Yes, sir.
Because what I was watching all throughout, it was very informative. Very informative.
Now, HLA-B27 has been discussed so much in greater detail, but as far as psoriatic arthropathy is concerned, HLA-B6 is one which is positive for psoriatic arthropathy. So that also we should remember.
Okay. So if
I
think we can conclude the meeting.
Yes.
Yes,
So,
we think as Rajesh is not there, so
our secretary.
as an office chair after Rajesh, I thank you all for giving a wonderful lecture and a wonderful webinar. And I convey my heartful thanks to you. And I know Rajesh will continue to do this thing. And hope to see you all in Kotak in next hand meeting.
Right.
Yes,
Sure.
sir.
I will like to end with a concluding remark. There was a Dr. Alok talked about osteoporosis. So osteoporosis is always an accompaniment in spondyloarthropathy.
Right.
But unfortunately, if you scan your patients on the DEXA scan, also will not show osteoporosis. So there is hidden osteoporosis. Keep on treating these patients for osteoporosis as well. Otherwise, you will get almost a chance fracture. And I have seen few patients of these fractures. It seems as if the vertebra has been cut into two, and this is very painful. So prevention is better. Right. Thank you. Thank you, everybody.
Thank you, sir.
Thank you very
Thank
much,
you,
sir.
sir. Thank you, sir. Thank you, sir.
Right.
Thank you. Thank you. Jai Hind.
Jai
Jai
Hind.
Hind, Sanjay.